Buenas tardes, les doy la bienvenida a la sesión científica de la Academia Argentina de Cirugía de hoy, 27 de agosto de 2025. Eh, Agradecemos la presencia de todos los miembros académicos y así como otros colegas interesados en nuestra actividad científica que se suman a esta sesión. No habiendo discusiones atrasadas y habiendo sido aprobada el acta de la sesión anterior, le doy la palabra al doctor Sunjo Gion para que nos lea los asuntos centrados. Doctor Gion.
Buenas noches, muchas gracias, señor presidente. Quienes se encuentran presentes en las sesiones tanto por Zoom como por YouTube pueden registrar su asistencia a través del link que se provee en ambas plataformas. Recordamos que la asistencia a las sesiones del año anterior, en el porcentaje que marca el estatuto, es uno de los requisitos para ingresar como miembro asociado o pasar de miembro asociado a miembro académico. Los asistentes a las sesiones que no sean miembros de la academia pueden hacer preguntas o comentarios por el chat de YouTube. A fin de cumplir con el objetivo de la academia, es decir, el estudio y difusión del progreso de la cirugía, su campo de acción, sus competencias específicas, la comisión directiva enfatiza la necesidad de que los miembros de la academia envíen comunicaciones, casos interactivos y videos científicos para integrar las sábanas de futuras sesiones. Recordamos que no es un requisito que las presentaciones sean inéditas. Existe interés en que los trabajos leídos en esta academia, y que sí sean inéditos, se envíen para su publicación a la revista Argentina de Cirugía. Los manuscritos deben ser enviados por los autores a la secretaría de la revista. La presentación deberá ajustarse a su reglamento disponible en la página web de la revista. Todos los trabajos serán enviados a revisión por pares de acuerdo con las políticas de calidad editorial. La comisión directiva recuerda la importancia de mantener al día el pago de la cuota societaria, ya que este recurso económico resulta imprescindible para cubrir los gastos corrientes de las actividades de esta academia. Trabajos a premio. La comisión directiva anuncia que se ha prorrogado el plazo de inscripción de trabajos para optar al premio Academia Argentina de Cirugía 2025. La nueva fecha es el 31 de agosto del corriente año. Los trabajos deberán ser inéditos, realizados en Argentina y los autores no ser miembros de esta academia. Las condiciones están detalladas en el artículo 29 del estatuto que se encuentra en la página web de la academia. Finalmente, el próximo miércoles 3 de septiembre tendremos la comunicación Tratamiento percutáneo de las estenosis biliares benignas con stents biodegradables, de indicaciones, materiales, técnica y resultados a corto y largo plazos. Los autores son los doctores Pablo Huespe, Sebastián Ollero, Juan Medina, Gustavo Boldrini, Juan Carlos Spina, Martín de Santibáñez, Daniel de Agostino, Juan Pecol, Eduardo de Santibáñez y Sunjo Gion. Será relator el académico Sunjo Gion. Y los comentadores, los doctores Carlos Colombres, por la Academia Argentina de Cirugía, Eduardo Houghton, por el Hospital Rivadavia de la Ciudad de Buenos Aires, Juan Lamotte, del Hospital Provincial de Neuquén, Ariel Sayek, del Hospital Zonal de Trelew, y Francisco Suárez Sanzorena, del Hospital de Clínicas de la Ciudad de Buenos Aires. Nada más.
Muchas gracias, doctor Gion. Hoy tenemos un lujo. Vamos a tener una sesión dedicada a la docencia de cirugía y contamos con la presencia de dos invitados extranjeros que van a disertar sobre este tema y van a y van a actuar como comentadores los doctores Alberto Cariello y Marcelo Figari. La presentación está a cargo del miembro honorario doctor Alberto Ferreres. Así que, doctor Ferreres, adelante, por favor.
Muchas gracias, presidente Montesinos. Voy a compartir pantalla. Bueno, muy buenas tardes a todos. Para mí es un placer y un privilegio tener la posibilidad de presentar a la profesora Brenessa Lindeman y al doctor Daniel Chu. La doctora Brenessa Lindeman hizo su pre-medical school en la Universidad de Louisville y obtuvo su título de doctora en medicina en Vanderbilt. Posteriormente fue residente de cirugía general en Hopkins y completó un fellowship en cirugía endocrina en el Brigham and Women en Harvard University. Posteriormente realizó un fellowship sobre investigación en educación en cirugía. Desde el año 2017 se desempeña en la Universidad de Alabama en Birmingham, donde es la directora del Fellowship de Cirugía Endocrina, profesora asociada de Cirugía y Educación Médica y dean asistente para Educación Médica de posgrado en la Escuela de Medicina de dicha universidad y Vice Chair de Education en este departamento. Hoy en la mañana tuvimos la oportunidad de escucharla en una jornada sobre liderazgo en medicina y es una experta reconocida a nivel nacional de su país e internacional sobre Entrustable Professional Activities. Por su parte, el doctor Daniel Chu ha sido un frecuente visitante de nuestro país. Creo que esta es la tercera vez que él se encuentra, ya que es la quinta vez que organizamos un evento en conjunto con la Asociación para la Cirugía Académica. Él se graduó en el 2002 en la Universidad de Yale como Bachelor in Science y como médico en Hopkins. Completó su cirugía en BU en la ciudad de Boston y posteriormente un fellowship en cirugía colorectal y un máster en ciencia en salud pública en la Universidad de Alabama en Birmingham. Es el profesor de cirugía, es el director de la división de cirugía gastrointestinal que lleva el nombre del doctor Selwyn Vickers, a quien me voy a referir posteriormente, y es quien está a cargo de la parte internacional en la Asociación para la Cirugía Académica. Es miembro de múltiples sociedades nacionales. El año que viene ingresará a la American Surgical Association, que es un distinguido miembro de la SSIT, la Sociedad para la Cirugía del Tracto Alimenticio. Una de las habilidades del Dr. Chu es su habilidad con la parrilla, o sea que hoy a la noche seguramente se va a lucir y una de sus cuentas de Instagram es The Grilling Surgeon y lo he comprobado personalmente en su casa. Y estas son imágenes previas de los cursos que se dieron el año pasado con el Dr. Chu. Un punto importante a destacar que los dos invitados de esta noche son faculty en la Universidad de Alabama en Birmingham, en el sur de los Estados Unidos, que tiene un departamento de cirugía ampliamente reconocido y un programa de entrenamiento que supo y sigue estando entre los en el top tier de los Estados Unidos. Acá tienen algunas imágenes y quisiera hacer referencia en particular a tres individuos. Uno de ellos es el doctor Kirby Bland, cuyo vice chair fue el doctor Joaquín Aldrete, quien me abrió las puertas de los Estados Unidos como sponsor cuando tuve la beca en la American College, hermano del anestesiólogo. El del medio es el doctor Selwyn Vickers, quien fue no solo jefe del departamento de cirugía, sino dean de la Escuela de Medicina y actualmente es el CEO en el Memorial Sloan Kettering Cancer de New York, y el actual jefe de departamento, el doctor Herb Chen, también cirujano endocrino y con bien imágenes de su visita a nuestro país el año pasado. Y con esto dejo presentados a los dos y espero disfrutar las charlas de ambos. Creo que en primer lugar el doctor Chu. Muchísimas gracias.
Gracias, doctor Ferreres.
Oh, great. Is it okay for me to get started?
Okay, go ahead.
Wonderful. Okay, I'll share my screen. Okay, does that work for everybody?
Okay.
Okay, wonderful, great. Well, first of all, thank you all very much for this really special opportunity to share some of our work on health literacy. Thanks to Alberto Ferreres really for this friendship that has allowed this to happen. And thank you to all of our leadership for this society and this academy for this evening with you all. So my name's Dan. I am colorectal surgeon by trade and division director for GI surgery at UAB. And I will be sharing the next 20 minutes or so some of our work on health literacy and why it matters. And feel free to interrupt with questions or comments in the chat box. So I have no commercial disclosures, but a lot of the research I'll be sharing in here about health literacy is funded through multiple grants and through entire teams of people on my lab that have really been the cornerstone of getting this work done. So I have to thank them all for that. So today I hope to tell a story about health literacy. I want to tell a story about why this is a problem. I want to show why it matters for everyone on this call, and also share some work in Alabama and predict some of the future and why this is still very, very relevant and important. So the problem of health literacy is very real and cuts across all specialties, not just surgery. The United States defines health literacy as the degree to which you as a person have the ability to obtain, process, and understand information to make decisions. And everyone has to do this. In the last 10 years, this has evolved into something more. Now it's not just your health literacy as a person, it's also your health literacy as an organization. So your hospital has an obligation to help patients understand information to make decisions and to navigate the healthcare system. And when you think about all the things you have to do as a patient, right, or as a family member going through the healthcare journey, you have to do all of these things that are shown here. And guess what? All of this applies in surgery. And so each of these steps requires health literacy. And so at every point in surgery, we also have issues of health literacy. If you look at the journey from when the patient gets sick to when they meet the surgeon, to go to the hospital, to get operated on, discharged, and go home, we as surgeons think this. You need surgery, sign this, read this, I heal, and then you're going to be discharged, and you will be just fine. But in reality, I would argue that most patients actually don't understand anything that we're saying and are completely confused as to how to take care of a new ostomy or a new wound when they go home. And so this is health literacy. And so at every step, patients have to obtain, process, and understand information. And so this is why health literacy is also very important in surgery. Now, multiple levels of health literacy. The classic one is print literacy. That's how it all started. But this has evolved into oral literacy, technology literacy, information literacy. The world now is very complicated. And so health literacy has also become more complicated. And we all on this call have to do each of these things as we navigate the healthcare system. For the researchers on the call, there certainly are ways to quantify health literacy as shown in this area. This is a great website, BU, the Holy Bible of all health literacy measurements. And you can see that this has evolved from 1991 with the very first health literacy test where you just read a list of words to the more recent test in 2012 where there's single items or 4-item tests that can assess your level of health literacy. And this is important because multiple national agencies, especially in the United States and across the world, including the WHO, all have language on health literacy, why it matters, and why we have to do something about it. In the United States, one of the biggest assessments of health literacy happened in 2003 when they went across the United States and measured health literacy. And this is what they saw. They saw that of all measurements of health literacy, the sliver in green, 12%, this is health literate people. These are people who can calculate the deductible on insurance. So that's good, 1 out of 10. But look at this. The rest all have trouble. 9 out of 10 adults in the United States have difficulty using information to navigate this system. And this is irregardless of your education level or your background. My own father, who's a mathematician, PhD in math, thinks on another level that I still do not understand, could not understand how to take his colonoscopy prep when he got the instructions of a booklet of how to do it, right? So this happens to everybody, and it's kind of ironic, actually, really. When you look at health literacy in the United States, this is what it looks like. Red is bad, so is orange. And that there on the left is our state of Alabama, which has huge swaths of red and orange, which tells you how low health literacy is in our state. So this is a major problem across the entire country. And really, if you look across the world and you measure health literacy, you will see low levels of health literacy in every society. But what's really troublesome is that health literacy has been linked to all of these outcomes shown here, from mortality to ER visits to readmissions. So this is a problem. It affects major health outcomes for people. And this model is a model that puts it all together and tells you how health literacy drives health outcomes. Walking you quickly through this slide, a patient comes to your clinic with a set level of health literacy. That doesn't change. That level is predetermined by all of these demographic and social determinants of health that have happened before the patient came to your clinic. But health literacy is related to health outcomes. But you can do things in the middle to modify the direction of that health outcome. So a patient with low health literacy and a new ostomy is at high risk of being readmitted, but they are not fated to be readmitted. If you do better education at the system level, have better support technologies, have better provider communication skills and teaching abilities and time spent teaching patients how to take care of an ostomy, you can change the direction of that outcome. And so this really framework is what we use a lot to think about health literacy and why we can do something about it. Now, across the entire specialties in non-surgical fields, COPD to CHF to end-stage renal disease, a lot of work in health literacy has been done, but very little has been done in surgery. And so this is what got us going. Now, you might ask, how the heck does health literacy relate to surgery? Well, think about surgery and how it all started back in the days of the barber, right? We have evolved from those days to enhanced recovery programs. And hopefully people on the call here know a little bit about enhanced recovery programs, one of the biggest innovations in the 21st century. But Professor Khaled in Denmark put it all together and said, hey, can we recover patients better by doing all these things? This is no rocket science. These are things that we all intuitively do individually. But he was brilliant enough to put it all together in 2005 with the first enhanced recovery program in colorectal surgery to say that if we do all of these elements, guess what? Patients can do really well. And they did. And in fact, if you look at modern enhanced recovery programs, it looks like this. It's multi-level, it's across the spectrum, it takes care of patients from the very beginning to the very end, using all those simple things that have been shown to help patients. And this is the most modern, most recent version of enhanced recovery through the International ERAS Society. 24 items that are shown here, right? That you can see and look at it and see if you do it for your own patients. And you probably do. And those are all elements of enhanced recovery. But here's the kicker. All of these 24 components, even though you say you order it and put it down for a patient, is it actually followed through? And I would argue that each of these steps is actually quite dynamic, and patients actually have a bit of a say in terms of whether or not it happens or not. So things such as bowel preparation. Do patients actually take bowel preparation? Do patients actually do screening? Do they get information before surgery? And the reason I say this is because we have observed a very interesting phenomenon in the United States and in other countries, whereby on the x-axis you have health literacy. We know enhanced recovery works best if you adhere to 100% of those components. If you don't, then you're not really doing enhanced recovery. And so you can see patients with high health literacy have the highest probability of following almost 100% of those enhanced recovery components versus someone with low health literacy actually has very low adherence to those enhanced recovery components, thereby having actually terrible outcomes. So this is a mechanistic way of why low health literacy patients may have poor surgical outcomes, is this adherence to steps that we know benefit patients. And so for us, this is a big, big thing here for us to see this, because this really makes us ask more questions of how can we change the direction of this graph. And you might ask, does it really matter? Well, it actually does. If you look at adherence to diet, this is using machine learning across a big database at UAB. If I walk you through this, at the very top, you can see that overall at UAB, 75% of our patients adhere to early diet, meaning you feed a patient pretty much the day of surgery. And we know this stimulates the gut and makes things work better. If this patient gets pre-op education, they have a 77% adherence rate. If they do not get pre-op education, they have a 59% adherence rate to getting an early diet. So it's not just providers putting an order for a diet for everybody. There's something here that's dynamic that actually differentiates between your adherence rate purely by whether or not you received good pre-op education. And this is machine learning. So we stuck the whole database into the machine, and it basically told us what was the most important branch point, the first branch point that matters the most. And this idea of pre-op education came up throughout this whole enhanced recovery pathway. And you can even see in the lower left, which is really fascinating. If you look at overall adherence, we know enhanced recovery, you need to be at least 70% adherence rates. You can see that pre-op education is actually the very first branch point as to determine whether or not you're a high adherence person or a low adherence person. And so this tells us that we have a point of effect that we can drive things to make changes downstream. So because of this, our work has really been focused on this framework. In surgery, you can easily show through retrospective studies that at least 30% of surgical patients have low health literacy, but very few studies have done any interventions. Even fewer have tried to understand it. This is one of our early works to really show the gap in knowledge in this space. So at UAB, we've been measuring health literacy since 2017 and 2018. And because of all this data, we can actually differentiate now people at UAB who are at the highest risk of having low health literacy, in this case, the African American males, versus those who have lower risk of having low health literacy. And so this research has really been able to show us now and quantify the associations of health literacy with certain demographics, outcomes, you name it. Now, everyone on this call, I think, intuitively knows if someone doesn't understand something. Coming out of your clinic room, if patients have these characteristics, vacant looks, asking no questions, these patients probably have low health literacy. They're not trying to act dumb, so they're not going to ask questions. They're going to have the shortest clinic visit trying to get out of that clinic room. And guess what? They'll leave the clinic not fully understanding what's about to happen. Now, our group has spent significant time showing the effects and association of low health literacy with outcomes such as readmissions and post-op complications. But more importantly, we've done qualitative research, which has also, in another roundabout way, consistently showed that low health literacy absolutely is something that patients want and desire. They want accurate, trustworthy information. They want clear communication. So what have we done in Alabama to address these issues? Well, Alabama is certainly known for a lot of things for those who have not been to Birmingham, and I would welcome anyone here to Birmingham if you come visit. We're known for football. We're also known for food. Have one of the best restaurants in the United States before COVID. The chef there has other restaurants still open right now, and we're New York Times one of the top places to visit even before COVID, and still a great place to visit. So please come by if you can. But we're also known for bad things. The annual report for health rankings shows you where Alabama sits, and all the southern states sit in health rankings compared to our northeast and northern counterparts, which are healthier states. And Alabama sits right at number 46. So we're not doing great in terms of healthy state rankings. For those who haven't been, Alabama also has some of the worst poverty in the United States. The UN Special Rapporteur came to Birmingham in 2018, went about an hour and a half south and toward the city of Selma and Montgomery, and just showed abject poverty. Places that don't even have sewer systems, open defecation, right? Just terrible things that you would never expect to see in the United States. So this is going on in the Alabama backyard. And when you look at health disparities, the maps always look like this, everything in red. And Alabama's right there in the middle of all this. Now, so what can you do about this? Well, so our efforts have focused specifically on these specific sections. So readability, what do I mean by that? Well, if you go across and send students across our enterprise to collect all patient education materials and rate them by readability scores, the NIH and AMA recommend 6th grade reading level or lower. But you can see, on average, all of our materials at UAB are well above the 6th grade reading level on average. If you look at which specialties have anything at the 6th grade level or below, all of those specialties in red have nothing written at what the NIH or AMA recommend, including my own specialty, which is very embarrassing, of colorectal surgery. You can see that plastic surgery is very good at this compared to the other specialties. If you use other ways to rate the readability and understandability of materials, this is a great assessment tool called a PMAT. What you see here is UAB in green on the far left and all kinds of other programs on the far right of understandability and actionability. Just another measure of how understandable and effective a written material is. And you can see that a lot of other countries like Canada are really good at making materials that are understandable and actionable, but UAB, we're pretty bad on the far left. So tremendous opportunity to improve readability. Ironically, if you look at the New England Journal of Medicine in 1980, people actually started looking at this already, at the readability of surgical consent forms. So you can just take a look at this slide, which shows you that even back then, Dr. Grudner was calling out consent forms as being completely unreadable and excessively difficult to read. Guess what? This is 2025, right? And I think the same thing is still happening today with consent forms. Now, what can you do about it? Well, there's some basic things you can take from other industries, such as the graphic design industry and information design industry, to make things actually better. Simple things like CARP, C-A-R-P. This is a simple technique that makes things a lot more understandable. Contrast, alignment, repetition, proximity. What does this mean? Well, contrast. This makes it easier for the eye to see and to understand. Alignment is also makes the eye grasp things very quickly and not have to worry about the misalignment. Repetition and proximity. These are all simple graphic design elements that can improve written material and the layout of things. In addition, words are important. Words that are very long syllables, more 3 or more, are actually very difficult to understand for someone with low health literacy, but you can reduce it and change it from the 21st grade, for example, grade level for strenuous to something like hard or heavy lifting, which is much lower grade levels. Just like narcotic, you can change that to pain meds. So these are easy ways to convert words. Vanderbilt has a great Center for Health Communications that shows you on another level how you can take a sentence at the very top, change it to the 12th grade reading level, and you can see how they broke gastrointestinal to stomach or bowel, and they changed consult to call, to the 8th grade reading level, to the 4th grade, and then finally to the 3rd grade reading level, which is still conveying the same points to a patient, but is far more understandable. And so using this technique and using a lot of students, you can convert education material that looks like version 1.0, something that I made in my office I thought was awesome, but it really sucked, to something that's much more readable and understandable. You can run it by patients themselves, and you can make print material much more understandable. And you can see easily here how much more visual it is and more cartoon-like it is. There's a reason why cartoons are understandable by everybody, right? Even kids. It's because it's easy on the eyes. It can be very stepwise and simple, and makes it very clear points in each box. And this material can be designed and then tested with patients where low health literacy patients absolutely favor these newer materials. And you can take, for example, procedures that we all draw on pieces of paper for everyone, right? Everyone here probably draws for their patients, but you can actually also formally draw and make things also more understandable and for patients to visually see and understand. But of course, this is all very labor intensive. It's a phalanx of students, right, converting this material. So nowadays we might ask, can you use AI to do this job for you? And the short answer is there's a lot of potential for this. In one of our papers that we were looking at, we asked the question, can you use AI to generate new colorectal material? We use prompts that you can see on the right, and this is incredibly important when you work with LLMs and AI, is the prompt engineering. What do you actually include? The bottom line is the more specific you are using that metric prompt, the more readable or the lower the reading grade level for these materials. And so in this case, ChatGPT was good. Perplexity is another tool that's out there that they say is really good, but you can see here is not as good as ChatGPT. So for generating material de novo, meaning you just ask the question, give me some stuff on ostomy and how to take care of it, ChatGPT does pretty good if you use that metric prompt. Similarly, you might ask the question, can you convert existing materials to something that's also more understandable or readable? And so you can take materials that already are in your clinic, feed it into the AI, and spit out something new on the back end. What we showed here is that not all LLMs are the same. Gemini is actually probably the best in terms of converting materials from existing exhibits to the newer exhibits and at a more understandable grade level. So I think there's a lot more to be done here in terms of standardizing the approaches of using AI. And why is this important? Well, people have started to look at this also for consent forms, right? In terms of, hey, consent forms are terrible, right? This is 2017 with this publication. Ironically, this is what they recommended, 8th grade reading level or less, all the same things that you saw before. And people have done this. This is actually published in Nature, just like this past year. Using a simple prompt, this team just tested whether you can improve surgical consent forms using ChatGPT. And they're able to show that, yes, you can absolutely improve consent forms and their readability with these approaches. So pretty fascinating and a whole field of study that's starting to come about. But then at the end of the day, though, even though you can improve the material, a lot of reviews of all these interventions still show that it's still that one-on-one time that you as a doctor have with the study participant, with the patient, that is still most effective at improving patient understanding. Briefly touching on support technologies, this is another thing that's out there now. We have technologies that are on your phone that patients follow, like a map during their journey. It has great education material, shows you how to change your ostomy, like a cartoon. And basically, what all we've shown through this is that in the red are patients with low health literacy. And those surveys 1 through 5 are certain touch points. And you can see that the red does it almost as good as the green. And green are people with high health literacy. And so this is only simply showing that patients with low health literacy can use technologies. So these technologies are great adjuncts to help support the needs of those patients. Of course, there's still some subtleties we see here, but these technologies are here to stay, and so they should be used. And we're actually testing this right now in the Black Belt of Alabama, where we're testing this technology to improve colonoscopy screenings. Finally, communication skills.
Sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. You're using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Yeah.
So that patient probably didn't give Dr. House very good patient satisfaction scores, but Dr. House used teachback methods. And providers are very important. You as the provider, as a doctor, talking to the patient makes a huge difference in terms of what patients think about what's going on. Incredibly important and central. And if you were a fly on the wall and to put a tape recorder into a room with you and a new patient, in this case, we stuck a tape recorder with 4 new surgeons talking to new patients and analyzed the conversation, we could see that we're all over the place. People talk at different speeds of rates of speech. We all talk faster than normal. Some surgeons use really big words, as shown on the left there. We're using more understandable words, like surgeon number 2 uses really great understandable words. Surgeon number 3 is pretty bad. And ironically, the faster you speak, the less understandable you get. So patients are being hit with surgeons who talk really fast, who use big words, and spend very little time in the clinics. And so it's no surprise then that patients at low health literacy are at tremendous risk of having the shortest clinic visits and also reporting the least understanding after their visit with surgeons. And so this is a problem, right? That even at the patient encounter level, that one-on-one time, we have an opportunity that's being missed. And we know what we need to do, which is the great irony. We know we need to spend more time to teach back, to slow down, to use plain language, pictures, and teaching tools. But that's the interesting kind of conundrum, is that we know what we need to do, but how can we make and help people do it better? One of the things that may be out there is Dr. Schwartzy at Wisconsin does a great way of kind of helping patients understand risk using a best case, worst case scenario. We don't have time here to go into this detail, but if you haven't heard about her work, I would highly recommend looking at it because it's a very simple way of portraying risk for surgery for patients that has been shown to really help them understand what's about to come. And so we take this all together now. And one of our big grants right now is focused on developing an intervention shown in the lower left to improve and address this gap in health literacy, engaging patients with visual aids, coaching providers, training organizations. And by doing all this together, we think we can change the direction of this graph. And so we're taking best practices from the graphic design and movie industry. You can see this looks sort of like Spider-Verse for those who've seen that movie. So it's very kind of cartoon, anime-ish to help patients have a really engaging video and learning session about enhanced recovery to help patients understand why each step is so important, why they should walk the night of surgery, why they should take an early diet the night of surgery, and to improve that adherence rates for patients with low health literacy. And then finally, for those who still might not believe makes a big difference, this is a great study with carotid disease in patients where they did a randomized study, and all they gave the intervention group was on the left. They gave them one sheet of paper, literally what's on the left of this slide, that shows the patients the degree of carotid disease, the plaque in their carotids. That's all they gave them. It helped patients understand their disease burden, and guess what? It changed their entire health behaviors for a year, so that by year's end, their cardiovascular scores were significantly better by those who had this sheet versus those who did not have this sheet. So a simple intervention, no $2 million robot here, just a simple piece of paper that made a tremendous difference in health outcomes. So ultimately, I think our goal is really to equip each step of this surgical journey with best practices in health literacy. Certainly our journey in our lab has been very up and down, but we've kind of managed to tell a story right now of health literacy and working our way through more future work in addressing the red and orange that you see here in the state of Alabama to make it a more equitable state. So certainly a lot of different ways and strategies to do this, and hopefully in our lifetime, we'll be able to see maps that look much better like this. And I'd like to thank everyone, for your attention. Happy to answer any questions, but ultimately hope to convince you that health literacy absolutely matters and that there are things that you can do even today as you walk out to your clinic tomorrow to keep it simple, clear communication, use technologies, and make a difference with health literacy. So thank you again for your time, and we're happy to answer any questions.
Okay. Well, thank you so much, Dr. Chu. We prefer to listen to the two lectures, and after that, we'll begin with the questions.
Perfect. Thank you.
So, Dr. Lindeman, please, can you share your screen and begin?
Yes, thank you very much. Someone tell me if you cannot see my slides. But I titled my talk, The Next Frontier in Surgical Education, that is competency-based assessment. I hope to convince you all of that after our time together. So these are my disclosures. They all relate to the study of competency-based assessment, specifically entrustable professional activities. And the three organizations whose logos are shown at the bottom are groups with which I've been privileged to do this work. So I imagine that you will probably be able to see early on that I am very biased toward this concept, and hopefully I will convince you that this is a good thing to do. So I wanted to begin setting the stage and the context for the impact that a single surgeon can have over the course of their career. So over a lifetime, if we have one surgeon and they care for about 500 patients per year on average, over the course of a 30-year career, they will end up serving 15,000 patients. And in the United States, we graduate 1,350 approximately surgery trainees every year. So each class of surgeons is going to serve 20 million patients over the course of their careers. And if you think about that magnitude, including even here in Argentina, if there's even one person that is not trained as well as we would hope for them to be, it can have a huge ripple effect out across the entire population that we want to serve. So how do we want to measure whether surgeons are prepared to enter practice? Well, we like to say that we're measuring the knowledge that they have gained, whether they can exercise judgment, and if they have the technical skills that we have constructed our systems of training to impart to them. But believe it or not, I'm here to tell you tonight that we are actually all bean counters. And I don't know if this is a phrase that you are familiar with, but in English-speaking areas, we would say bean counters are people like accountants or administrators. They're people just keeping track of dollars and cents and checking boxes. And that is precisely how we have measured whether surgeons are ready to enter practice. We count the number of cases that they do. But what everyone on this call knows, but we don't often talk about, is that just because you manage to finish an operation does not mean that you would be competent to do it on your own the next time around. Our current system of training is one of fixed time. So if you want to be a surgeon, at least in the United States, you sign up for 5 years of clinical training. But that paradigm does not account for the fact that people develop knowledge and skills at different rates. So at the end of that fixed period of time, we are left with variable outcomes. Not everyone makes it to the goal that we would want them to. And there's data to support this. This is from a colleague, Brian George, from the University of Michigan. These are operative performance assessments from the last 6 months of general surgery training. And we can see that almost everyone was competent to perform an appendectomy, thank goodness. About 80 to 85% could take out a gallbladder or repair a hernia. But by the time we get to Dr. Chu's specialty, taking out part of the colon, we lose almost 30% of general surgeons in their last 6 months being competent to take out part of the colon. That, to me, is a problem. So I would argue that our goal system then should be one in which we focus on and fix the outcome of training. And that may mean that some people need longer than others to get there. I would also argue that what most of us do on a day-to-day basis, every time we line up across that operating table from our trainee, we are thinking about how much we trust this person to be able to perform the operation that we're getting ready to do. Like if I fainted and could no longer, be conscious, would this resident be able to do the case? And that influences how much I let them do. So on a good day, I might be thinking, well, I can let the resident start and I will scrub in for the key portion of the case. Or on a not so good day, I'm thinking about the rumors I have heard about how good this resident is or not. The problem is none of these decisions that we already make on a daily basis are documented in any way, nor are they based on any standardized descriptions of behavior, such that what I think is good performance in a cholecystectomy and what Dr. Chu thinks is good performance might be very, very different things. So let me introduce to you a concept you may already be familiar with, and that is one of entrustable professional activities, or EPAs. These can be defined as essential tasks of a discipline that an individual can be trusted to perform independently in a given context. That's a pretty simple definition, but it's still a lot of words. I often say that EPAs can be defined as units of work for a physician. And when you put them together, they are a mass of critical elements that define a profession or specialty. And for any other education nerds like me, we might think about how using EPAs shifts the focus of our assessment from competencies independently, like medical knowledge or patient care, and instead we think about the work that must be done. So I sort of think about it in this way, that EPAs are the culmination of the competencies, right? I have medical knowledge, I have communication skills, but it's how I put those things together to then be able to say, I could be trusted to evaluate and manage a patient with gallbladder disease. So this is a graphical demonstration of the 18 EPAs for general surgery defined by the American Board of Surgery. You'll see that 5 are shaded slightly darker. These are the EPAs that were tested in the 2-year feasibility pilot study, with the remainder shown in white boxes defined following that period of time. These EPAs are assessed using a micro assessment tool, and I show it on the smartphone because that's how it's most commonly performed. But if I blow this up, the date and assessor are pre-populated. The first question of 3 asks for the complexity of this case compared to others you've seen in your practice. The level of entrustment shown there with 4 options of limited participation, direct supervision, indirect supervision, and practice ready. And I will show you a bit more detail about this on the next slide, because it's much more than just a single rating scale where you're asked to choose from one of these 4 terms. Each entrustment scale is customized to specific behaviors for that EPA in order to create that shared mental model to help Dr. Chu and I get on the same page about what is good performance in a cholecystectomy. And the last box is very important for the trainee in providing them some narrative feedback. So I might say something about, good job using both hands to provide tension and counter tension as you dissected. Work on targeting the same area for spreading to enhance efficiency. I want to always have truth in advertising. So when people ask me how long it takes to complete these assessments, I tell them I time myself routinely, and my personal average is 39 seconds. So this does not take much time. And I actually try to do this after every single operation that I do with a resident. Now, I told you I would give you more detail about the entrustment scale itself. So this is the entrustment scale for the intraoperative phase of gallbladder disease management. And you can see that the behaviors increase in complexity throughout the scale. So the limited participation person, they can just describe things to you. They have a problem actually coordinating their hands and being able to identify things in a real person. The direct supervision person can tell you what the critical view of safety is, but they need assistance to actually obtain the critical view in the operating room, and they need prompting to keep the operation moving forward. The indirect supervision person can obtain the critical view of safety in a routine case, and they move fairly fluidly through the operation. But if there's scarring or inflammation, that trips them up. The practice ready person can basically do any operation that you put in front of them. Now, at this point, you might be asking yourself, okay, that sounds great, but is there any evidence that this works? And so myself, our study group, as well as colleagues throughout the United States, have been working to build this evidence base to demonstrate the efficacy of this assessment paradigm. So I'm going to share just a brief snippet of some studies that have been done in the interest of time. But importantly, I wanted to point out these are the 5 EPAs that were included in the general surgery pilot. So 3 of them had an operative phase of care: right lower quadrant pain or appendicitis, gallbladder disease, and inguinal hernia. And that will come up again shortly in the next few slides. So if we look at data from the general surgery EPA pilot, these data actually are from my home institution, UAB in Alabama. And in this slide and the next, green is good. There were 5 levels of entrustment in the pilot, and so a 4 or a 5 are both shown in green, but we want to get people to green. And year of residency is shown in the x-axis, moving from year 1 to year 5 from left to right. So you can see that the older the resident is, the more experienced they are in general, the more green that they have, which is exactly what we would want to see. But the plot gets thicker because when we divide this out by non-operative phases of care compared to the operative phase of care, you'll note that in the non-operative graph on the left, there's lots of green, We trust early and often, starting in the PGY 1 and 2 year. But for the operative phase of care, on the right, we don't really see much green at all until the PGY 4 or 5 years. Whether this reflects our lack of trust or our residents' poor performance is impossible to tell from this study. But I will tell you that UAB is not alone, because these are the data nationally from 28 centers across the United States. And in the preoperative graph at the left, I've highlighted this purple line, which is appendicitis, which shows that for preoperative appendicitis care, people were achieving levels of green by the PGY 3 year, and they had achieved indirect supervision by the PGY 2 year. So that's pretty early. However, in the intraoperative phase in the middle, this teal line is gallbladder disease, and you can see that people are still hovering at low scores through the PGY 4 year, and it doesn't pop up really to entrustability until their PGY 5s. But that pilot is old news now. You might be thinking, well, show me some data from after the national rollout in July 2023. So these results are from last year or chief residents in surgery in the United States. And I will point out, these residents were not required to be assessed with EPAs during this first year, but 2/3 of chief residents in the United States received at least one EPA assessment during that year, and there was an average of 12 EPA assessments per resident. It's reassuring that the median entrustment level was at practice ready, or the highest level we could see for all of the EPAs except for 2. One was renal replacement therapy, which was not assessed very often, but the second was thyroid and parathyroid disease, which is corroborated by other data demonstrating that general surgery residents in the United States often have low self-efficacy to perform thyroid and parathyroid operations. Overall, 63% of assessments were at a practice-ready level, but that level was lower in the intraoperative phase of care as compared to non-operative phases of care, as we might predict based on the pilot data. And the mean entrustment scores were lower at the beginning of the year in July of 2023 versus the end of the year in May of 2024. We see nicely that practice-ready entrustment in this figure increased from 46% up to 74%. So now let's think about how we want to use this information going forward into the future, because I think for all of us, that is indeed where we are going to spend the rest of our life. So how can we utilize this paradigm to improve where we want to be? So I'll tell you that we're currently working on sort of permission slips for residents based on their EPA levels, that programs will be asked twice a year to take all of the assessment information they receive about a trainee and come to a summative decision about where they're at this point in time. So that if I'm preparing to do a thyroid operation with a resident, they can show me this permission slip. I can see that they are at direct supervision, and I can then calibrate how much autonomy I give, or what we're going to focus on with our teaching during those operations. We also have defined a research agenda for EPAs that includes 5 domains of inquiry. And we're in the process. I have grant funding. I'm very thankful to set up a consortium to have identifiable data about how people progress over time. Because I think with EPAs, for the first time, we're able to capture unique snapshots about how our trainees perform in all of the ways that we ask them to as residents, down in the trauma bay, in the intensive care unit, counseling patients at the bedside, actually performing operations, and put all of those snapshots together to form a much more comprehensive picture of who they are as a surgeon, And that is who I want taking care of me when I am facing the opposite side of the knife. So with that, I thank you again very much for the opportunity to speak with you all this evening, particularly to Professor Ferreres and the Argentinian Congress of Surgeons. I would be delighted to answer any questions that you have.
Thank you very much, doctora. Bueno, ahora damos paso a los comentadores. Doctor Marcelo Figari.
Thank you very much, Dr. Montesinos. I thank you deeply, Dr. Chu and Dr. Lindeman, for the fantastic presentations on, I would say, very important, relevant concepts related to medical education, especially in the field of surgery. Starting with Dr. Chu, I was highly impressed about your presentation on health literacy, and also very impressed about the data you show us about the relatively low portion of population that is really very proficient in order to understand the basic concepts on health management. No? And I think you were really very clear, crystal clear, showing several actions in terms of how to reach population, patients, residents, and colleagues. One question I have is having the concept that communication is a very important skill to be developed in the residency period, because it's the time you really have the possibility to raise the level of everyone perfection in the surgical field. If you have special simulation activities in your residency and fellowships, in order to train people not only how to speak with the patient, but also to understand how to manage the conversation and how to realize that the patient really understood what we were trying to say. I think that is really a very important concept. I would like to know, how do you organize educationally during the residency period?
That's a great question. Thank you for that question. So that's something that we definitely recognize. So part of one of our grants that I showed, where we're working on not only improving the patient-facing side of education with visual aids and videos and you name it, we also have a provider-facing side where we recognize that providers need more coaching and training in best practices in health literacy, like the way you talk to a patient, like the way you handle a clinic visit. There's opportunities. So we're developing, I would say, almost like a curriculum. It was almost based on existing materials already, actually. The AHRQ actually has a whole set of materials of what providers should know to be health literate. But we're trying to take that and deliver it in a more engaging way to providers, so that at UAB, for example, all new residents, all new doctors have to sit through all these training modules, right? That like make you tear your hair out. They're so boring, right? But can we actually put something there that's more engaging, that then helps patients, providers realize that there is a major issue with health literacy at UAB, and that you can do this, and it's really easy. And here's a video that shows you how you can do the teach back method with the patient, and look how easy it is, right? And not only train providers like doctors, but also train nurses. Because for us, it's a sandwich approach too. As a doctor, you're not going to be in a room for an hour. I wish, right? But you're not there for an hour. You're there for maybe 5 minutes. And then, but your nurse who follows you into that clinic room to do more work, if she says the same things and can reinforce the education, then you know what? That's a win. And if the next day the anesthesia clinic says the same thing that you said, that's another reinforcement. The problem is that doesn't happen right now, at least at UAB. Our anesthesia colleagues will say something completely different than what we say in our clinic on a Monday. So,
thank you.
Yeah, thank you for that question.
Thank you very much. Thank you very much. And to Dr. Lindeman, I enjoy your presentation. Here, Dr. Montesinos and myself have a lot of medical and educational things in common with you, because we are head and neck surgeons. So we are endocrinologist surgeons, and also we love medical education. Myself, I was the rector of our university at Hospital Italiano for more than 10 years, and I would say that the concept of entrusted professional activities is in Argentina not yet completely understood. But some universities started around 10 years ago, I would say influenced by the European schools, especially by the Dutch, but Ole ten Cate and the colleagues. And in our university, for example, we were able to organize some of the residence curriculum based on EPAS. So, and I would say from step to step, we were able to really introduce the concept in our community. Sometimes it's not easy to understand and not easy to test and to follow. But at least we have in our residency programs organized the concept of privileged or possibilities to really reach a different level of responsibility along the 5 or 6 years the residency is taking place. One question I have to you is, you can have, of course, as you have described, the fact that one resident is reaching the optimal outcomes in 4 years, another one in 5, and a different resident in 6 years. And this is a concept that is very nice, educational speaking, but not very easy to manage, taking care of our educational structure. Were you able to really flexibilize the curriculum periods in your country or in your organization in order to really consider that the surgeon was ready after 4 years and another surgeon needed 6 years to finish the program?
What an important and insightful question. Thank you for asking it. I wanted to make one comment, which is, EPAs, this system of assessment, is also poorly understood in the United States. So we are very much alike in that regard. And I think that what you describe, having this flexibility in the timing of training, this personalization of how long it takes me to train to become a surgeon versus how long it takes yourself or Dr. Chu to become a surgeon, is a laudable goal, but we are taking baby steps. Okay. And I'm going to coin a phrase from colleague Rebecca Mentor, who says, we have to move at the pace of trust. Okay. There's a lot of distrust in big systems. And so we're actually working with the board and the American College of Surgeons to start a pilot of something called promotion in place, where people that, as we assess them with EPAs, if they seem to be on an accelerated trajectory, that we could identify them in their 3rd year of training to then only do 4 years of general surgery, but stay where they are in their program and then act as an attending for an additional year or so thereafter. I hope that we'll get to what you describe, but eventually, but I think it's probably still 15, 20 years away.
Thank you very much. That's very clear. Thank you.
Okay. Thank you. Dr. Cariello, would you like to make your comments and questions? Go ahead.
Dr. Daniel Chu, thank you very much. I am really astonished with your assessment instrument to size the real literacy of the population. In our practice, we know for experience that the troubles caused by patient poor medical knowledge, both in treatment adherence and in pre- and post-operative care, but we don't document anything. We try to address this with more explicit informed consent and with images and even videos, but it is not easy and is not recommended by lawyers in some cases, and its application has always very heterogeneous. In 2020, the systematic review published in Health Literacy Research and Practice described several assessment instruments, and I'd like to hear your opinion on which one are the best for us to begin to assess the literacy of our patients.
So thank you, Dr. Cariello. That's a wonderful question. So, to begin, I would say that website at Boston University is the compilation of all the health literacy instruments in the world. So every country has developed this for their own countries and for their own languages, actually. So
Yes.
there are Spanish language health literacy assessment tools. And so the best tool is one that is honestly the best that fits into your workflow. One of my mentors in health literacy, Dr. Terry Davis, she invented the very first instrument of health literacy in 1991, the Realm test. And she always told me, she's like, Daniel, like there's like thousands, hundreds of instruments out there, but honestly, a patient either has health literacy or they don't. And so we get a little bit into the weeds a little bit when you're trying to distinguish, is it level 1, 2, 3, 4 of health literacy? So the instrument that we use after many years of work is the brief, the BRIEF. That is a 4-item question, very easy, done in 45 seconds, that just the patient reads it and then asks a simple question. How confident are you in filling out your medical information on a scale of 1 to 5? That's all it is. And it's 4 questions like that, self-reported, and then we have a measurement. And so a lot of the quantitative research that we use uses that instrument actually. And so it's very easy. The other instruments out there get more complicated. They require research assistants to actually deliver it and sit with the patient for 3 minutes, which isn't a lot of time, but it actually is a lot of time in your clinic. And those are really good, like the NVS, the newest vital sign, is probably one of the best tests. It's a numeracy test. It gives you the label of a food item, and the patient is asked questions that quizzes them on like how many calories are in there or how many serving sizes are needed. It's a numeracy, it's a math test actually. And that one's really good. That one truly discovers who has low health literacy. But for research, for practical purposes, those items like the brief are perfectly fine with being used.
Thank you very much. I think we use the very easy one.
Yes.
Well, Dr. Lindeman, for some time, we have used the mini clinical examination to evaluate resident physicians in our service. We evaluate surgical activities first in simulations, and then we supervise practice, but not document. I find the practice on the activities documented with the EPA very interesting, both for the resident knowledge and for the educator's assessment. I would like to know if you have surgical services with residency, as we do in our setting, that are quite heterogeneous in terms of the number of cases. Is in the same way of the question of Dr. Figari, that how can I do with the residencies with poor number of cases, half number of cases of the other central services of surgery?
Yeah, thank you for that question. And we face similar challenges in the United States, that some programs will have an astronomically high number of cases, and other programs, trainees may finish with half that number. And I think that's one reason that we're really trying to de-emphasize the number of cases that someone sees or operations they perform, please let me be clear. I think that you have to do a certain number. You have to have, a certain set of experiences from which to draw and to build your skill set. But the number of cases that you have to do or see is different for every person and likely varies based on their complexity. If you had 50 very straightforward gallbladders versus someone that does 25 that are a mixture of straightforward and complex cases, I'm not sure who would be the better trained surgeon. So I think that's one reason that we have to pair looking at the number of cases someone has done with individual assessments of their performance within each of those cases. And I think that this paradigm gets us closer to that goal of understanding.
Thank you very much.
Thank you.
Thank you, Doctor. Dr. Fabio Leiro, would you like to make some questions or some comments on...
Muchas gracias, señor presidente. Thank you for two great conferences. I think that just a small comment and a question for Dr. Chu I'd like to make. I think it's very interesting how poor communication impacts results, and I think that it's very difficult to verify the relationship between one thing and another, and Dr. Chu showed us that there is a relationship between these two things. I also think that communication is a very, very complex discipline. And I'd like to know if there is in the US a postgraduate degree such as a master's degree in health literacy, as there is, for example, in corporate communication. I'd like to know if he thinks that this is necessary and what role should we as physicians adopt in this regard. And also I'd like to know if they usually work with communication graduates to help in this issue of health literacy. Thank you. That's all. That's my question.
Thank you, Dr. Leiro. That's a wonderful question. And the short answer is that at an institution like UAB, and many institutions that I have trained at, there are no masters of health literacy that I have seen. Now, what I will say, though, that there are certain singular institutions like Vanderbilt that has centers for health communication. So those are very forward-thinking institutions where they have formed an institute and they have experts in all the different sides of linguistics and communications all together under one roof. And I think, and I visited that actually as part of one of my sabbaticals to learn from them to see how they did things. So no formal master's degree. Do I think everyone needs to be educated in health literacy? Absolutely. I think if you ask our residents and survey and what we've done with our assessments of organizations, there are huge gaps in training, in even just the idea of health literacy and the extent of the problem. So while, I don't know if I'll see a master's of health literacy at UAB, I think at the very least we can educate as many people as we can at all levels of care within our hospital system on the principles and the critical pieces of health literacy.
Thank you.
Thank you, Doctor. Okay. Is anyone else here in the Zoom who want to make a question? Dr. Hyun, please go ahead.
Thank you, Mr. President. Well, first of all, thank you, Dr. Chu and Dr. Lindeman, for the excellent conferences. I really enjoyed them very much. I'd like to ask Dr. Chu about the approach to patients who actually do not want to know, or they sort of say, doctor, you are the person who knows, so I rely on you and do as you think is best for me. So should they be, in a way, forced to get involved and to, understand every detail of what's going to, happen to them and what's going to be the strategy for care and everything, or should they be just left just the way they are and try to be with them, and take care of them in a different level, actually, in a more paternalistic level? So that would be my question for you. Thank you.
Thank you, Dr. Hyun. That is a wonderful, another great question. It's funny, we did a study at the Veteran Hospital. So in the US, we have a Veterans Administration where they take care of all the military and veterans hospitals. So these are very tough sons of guns that can withstand anything. And they flat out told us, I don't really care. You just do what you need to do as a surgeon, right? We trust you. So yes, that scenario I think does play out in many, many different areas. So my answer to, at least my initial answer to your question, your thought, is that on the one end, yes, that patient has great trust in you as a surgeon. But I think what you have to do as a surgeon is you still have to make sure that at least some critical pieces of that journey ahead is understood by the patient. For example, on the morning of surgery, under enhanced recovery, they will get a block, an intrathecal block, single injection that helps with pain control. That after surgery, pain instead of 10 out of 10, it'll be 1 out of 10, and they'll be only on Tylenol and Motrin. That's it, right? Under enhanced recovery. We've seen that there are quote unquote high refusal rates of blocks on the morning of surgery for patients with low health literacy. Because what happens is the patients don't get good education about it. The anesthesia shows up and says, we're going to stick a needle in your back. The patients are like, whoa, 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 I'm not going to undergo that. And anesthesia says, well, I'm not going to spend 15 minutes talking to you about this. I have another patient to see. Patient documented, refused, spinal block. Let's move on. And then the patient doesn't benefit from it and wakes up with 10 out of 10 pain and has a horrible experience. So I think I think enhanced recovery is actually a great excuse, a great way to really conceptualize the key elements of what a patient actually does need to know so that they can adhere to those steps, right? So a patient might not care, but the patient still needs to know that they should walk the night of surgery. They should have an early diet. They should get the pain block, right? Those are some very basic stuff that I think enhanced recovery does that you do need to make an effort for. Now, the catch too is sometimes the other way around that is you talk to their family member. So one of my things is a patient with low health literacy, you have to have someone else in that room with them, meaning a family member. And that person can be a tremendous help and a good strategy to sort of circumvent some of those challenges that might present with that scenario.
Thank you very much. And if I may, Mr. President, a question for Dr. Lindeman. So it seems like there might be a sort of a turnover of the paradigm in which now the system has to be adapted to the student or to the trainee, instead of a trainee adapt rigidly to the system, to the educational system. But how tolerant can a structure, an educational structure, be to trainees who need more time and need more training and need more opportunities and need more, because in surgery there seems to be a concept, which may be right or not, that you have to sort of adapt your personality to critical situations, and you have to be able to respond and to act under pressure and all that. So what about those concepts? Should they be revised, or in order to be more empathic to a trainee who who cannot adapt rapidly to this system? Thank you.
Yes, thank you so much for that question. Again, you all are hitting at all of the important issues that go along with surgical education. And what I would respond to your comments is first to think about, what do we do now? So if we have a trainee that is struggling currently, we do, in the United States, we do one of two things. We say, oh, this person is really struggling. They're really not safe to enter practice. And we hold them back, and they have to repeat another year or sometimes more than that. And then on rare occasions, we part them from training. That is a very difficult thing to do, and there's a lot of legal risk in that as well. So more often, what happens is we say, well, they have a safe plan. They're only going to repair hernias, or they're only going to do X, Y, or Z, and we send them out into practice. And then it turns out if you follow those people later over time, if they become board certified, they can go out and do whatever they want. So to me, it's a question of how do we protect the public and honor our commitment to patient safety? Now, along with that, studies of time variable training have shown that less than 20% of trainees actually need more time. And so I think that it's not actually about changing the system to make the system bend to the will of the trainee. I think it's much more about utilizing a system of assessment to identify people earlier. We have shown that we're going to start seeing signals early in training about people that are having difficulty within the first 2 years. And so maybe we do need to help that person and say, well, maybe you don't have the ability to act quickly, and maybe you need to choose a different specialty. And we're able to do that without wasting a lot of their time.
Thank you very much.
Okay, any other question from the Zoom? I guess there's no question from YouTube. Okay, I'm afraid we have the same kind of problems you show here about literacy in patients and education in residents on your 2 excellent lectures tonight. So we have nothing else to do. Dr. Ferreres, you want to close the session? Are you there?
I think he might be hosting some people. Some of our team members are here at his house. They just got here, so they just rang the doorbell.
Oh, it's not here. Oh, I'm afraid. I'm sorry. Okay.
Or preparing the barbecue, maybe.
He is preparing the barbecue. I can smell. We can smell the smoke right now. There's a lot of smoke here.
Okay. Usually, I allow the one who invite the people to close
The session.
but this time we can say only that thank you very much, both of you, for your excellent lectures, and for the rest of the audience, to invite them to the next session next Wednesday. So thank you very much to all of you, and levantamos la sesión. Muchas gracias.
Very much.